Hi, I'm Dr. Lori Schleicher, the hematologist at Down East Hospital, and I'd like to take this opportunity to introduce myself to you and let you know about some of the hematologic and infusion services that we have to offer now at Down East Hospital. I'd like to present a short case today about iron deficiency anemia. As you can see, this is a blood smear that is consistent with classic iron deficiency with increased central pallor, uh, red cells of various size and shape, and even some elongated cells. So the case that we'll discuss today is of a 36-year-old woman who presents with symptomatic anemia. She was started on oral iron approximately 3 months ago. Her initial CBC revealed a hemoglobin of 8.2 with elevated platelets and a normal white blood cell count. The MCV at that time was 65. Her ferritin was low at 10, and TIBC was elevated at 425 with an iron of 40. After 3 months of oral iron therapy, she returns for repeat CBC. On repeat CBC, her hemoglobin is essentially unchanged at 8.9, and her MCV remains low and platelets remain elevated. So this brings up the question, what are the causes of failure of oral iron? And so on further investigation with the patient, she reports that she has been taking the ferrous sulfate once a day only. The reason for this is that it's bothered her stomach some, and when she tried to take it more frequently than that, she got increased GI upset and constipation. One other possibility is ongoing losses. So a GYN history reveals that her periods last for approximately 4 to 5 days, but the first 2 days are fairly heavy, requiring 2 to 3 pads per day, with occasional passage of blood clots. And a third thing to consider is poor absorption. She also reports that for the past 2 years, she's had loose bowel movements with cramping, which occurs about 3 times per day, every day. At this point, the patient opts for a course of IV iron with iron dextran. 4 weeks later, her hemoglobin is repeated and it's 12. She comes back for a 6-month follow-up, at which time her hemoglobin is again 8. Further investigations reveal serology that's positive for celiac sprue. So let's delve a little bit further into this topic of iron deficiency. First, sometimes it can be a difficult diagnosis to make just on laboratory values because of some of the variability of the different tests that we use. Ferritin is an acute phase reactant, so this must be kept in mind when you have a patient with chronic inflammation. What we know is that if your ferritin is above 100, there's about a 95% chance that you have stainable iron in your bone marrow, which is the gold standard diagnosis, though we don't want to put every single patient through such a procedure. We also know that if your ferritin is above 200, you have about a 98% chance of having stainable iron in your bone marrow. Though this doesn't rule out the possibility that you could have functional iron deficiency, in which case the degree of inflammation is such that the body cannot access those bone marrow stores. The TSAT is not always reliable, as the level of serum iron changes based on time of day and what you've eaten recently. So one thing to keep in mind is once you've made the diagnosis, you always need to consider the cause. And the reason for that is that sometimes it can be the first marker of an underlying cancer. We know that loss of blood through the GI tract is common, and that we have to think about GI cancers. But of course, for menstruating women, menstruation and menorrhagia are the most common causes. And keep in mind that pregnancy and breastfeeding are nutritional states that require increased amounts of iron. So even with women that don't experience menorrhagia with multiple pregnancies, they may become iron deficient, particularly if they can't tolerate their iron supplements or the prenatal vitamins at that time. We also want to keep in mind some more uncommon causes, such as ongoing hemolytic anemia, which could be the case in disorders such as PNH, GU loss, which also could be from cancer or a benign cause, much more rare pulmonary hemosiderosis, and malabsorption, which certainly happens commonly after gastric bypass surgery, and of course as part of celiac sprue disease. So oral iron, in some ways it's a great treatment. It's cheap, it's convenient for the patient, but unfortunately up to 70% of patients will experience GI upset when taking oral iron. So there's a lot of non-compliance with this therapy. And a long course is required because you not only have to replace the iron that's needed to increase the hemoglobin up to normal, then you need to continue the oral iron to replete the bone marrow stores. So this can be cumbersome for some patients. It cannot overcome poor absorption, and it cannot correct rapid or ongoing blood loss, particularly for women who have very heavy menorrhagia. And that brings up the question of IV iron. Well, the big concern historically is for anaphylaxis. And some forms of IV iron do carry black box warnings for this, and some require pre-medication because of this. It's been called into question whether IV iron can increase the risk of infection. This has never really been proven. And some products are safer in pregnancy than others, and some products are more expensive than others. So let's take a quick review of some of the IV iron products that are available. So the first product here, the high molecular weight iron dextran, this has a very high risk of true anaphylactic reactions, and it's best that this product never be used. Its low molecular weight cousin, Infed, is a much safer product. It still carries the same black box warning as the high molecular weight form, but the anaphylactic reactions really have not been seen. You can do a total dose administration over 1 hour with this medication. And you don't have to pre-medicate. Most people would recommend pre-medicating if the patient has a history of any allergies or autoimmune disorders with dexamethasone or some steroid alone. But it does require a test dose, and you have to wait an hour after the test dose before total dose administration. Oops, sorry. Ferlicet and Venofer, which don't require test dose, but you cannot give a total dose administration, and the patient has to come back for multiple infusions, which is not so convenient. But as you can see, they are the only products that carry the pregnancy category B. So this may be a good choice for pregnant women. There are case series looking at Infed in pregnant women, and the suggestion is they're safe, but not as much data is available with these products. And finally, Injectafer, which is a newer product. You cannot administer the entire dose at once, but it can be administered over 2 sessions, 1 week apart. But of course, this medication is very expensive. So that might come into play when you're making your decision. So I'd like to thank you for taking this time to listen to this short presentation about iron deficiency, and let you know a little bit how to refer and some of the infusion services that we can help you with. So for any benign hematologic issues, except for bleeding disorders, we are handling right here at Down East, including all cytopenias, hypercoagulable states, myeloproliferative disorders, monoclonal protein spikes. And if you have any patients that you're interested in referring, here's our contact number, 207-438-8124. We can help coordinate with iron infusions, B12 injections, erythropoietic stimulating agents for patients with renal insufficiency or an anemia induced by inflammatory states or chemotherapy. And thank you again. Have a nice day.